it is a comprehensive women's health center. So, in such a place, you need to have a range of services that involve the management of both benign and malignant breast conditions. Certainly the thing that we'll focus on is managing cancer, but even from the perspective of managing benign breast diseases or high-risk disease, there needs to be a mechanism in one place for women to go. So, of course, I'm a breast surgeon, so I'll see patients who are coming in for a diagnosis of breast cancer, and I'll work with a multidisciplinary team of medical oncologists, radiation oncologists, pathologists, plastic surgeons, and so forth, who all work cooperatively to care for a patient as a team. As we do virtually now, we'll do it in a real way within the breast center in a physical space. And there'll be an imaging component as well, although the imaging won't be within the physical structure. It'll be coordinated with the physical structure so that if someone comes in for mammograms in radiology, she can coordinate that with an office visit with the physician in the center. Even though they're not in physical space, they'll be married together so that it happens in a relatively seamless way. I mentioned benign diseases. There are many women who may not have a diagnosis of breast cancer, but then they have issues of breast pain, breast lumps, other conditions. To be frank, it's a bit of a challenge for the providers to commit other their time to managing that, but there should be someone dedicated to that. So in the breast center, we will have a mid-level provider or a clinician whose job it is to manage patients who come in with non-malignant diseases, who can then, if they ultimately have the need for a surgeon, can be referred to a surgeon to care for the problem. So it's really, it's all happening within the umbrella of the breast center, but it's happening by someone who's focused on that problem. And the same person can manage a high-risk clinic as well for those who may have either a family history of breast cancer or a positive mutation or an abnormal finding that increases her risk of breast cancer. There will be someone committed to managing the patient's imaging, advising about risk reduction strategies, and providing ongoing follow-up until they ultimately, if they ever need a surgeon, they'll be able to make a referral to myself or one of my colleagues. The issue came about lymphedema. I know that someone here is touched by that problem, either directly or indirectly. And it's a problem that we all care about, but very few centers are really committed to focusing on screening the problem comprehensively. It is my vision, it's what we'll accomplish in the center, that when someone comes into the center for her follow-up, she may have her blood pressure checked, she'll have her pulse checked, and she'll be screened for lymphedema, because lymphedema is best managed when it's diagnosed early in a way that can be managed before it gets worse. And one of the surgical techniques that I've helped to develop to prevent lymphedema are strategies that sort of allow us to employ unique techniques during surgery to, well, as I said, avoid the problem. But we can't always avoid the problem, so we need to screen for it so that if it does develop, we can intervene before the stage, before it reaches the advanced stage. I think I've covered most things, but there are others. I just can't think of them all because I didn't really prepare for this time. But I was doing a procedure and I came here. Anything else you should mention?
Patient navigation, genetic counseling.
Oh yeah.
But wait, there's more.
There's more. So patient navigation. Well, this is really important. The things that I've described are just a part of the complex process of managing a patient from diagnosis to treatment, from screening to diagnosis to treatment. And it's really our responsibility as an institution, and it will definitely be our commitment as a breast center to provide resources, navigation, so that patients can look to us to provide guidance. Not only just patients, but physicians as well. If they have a patient with a problem, they don't need to figure out the continuum. They should just call and say, I have a patient who has this problem. Can you navigate her to a solution? It's really a responsibility that we need to bear. And if we have the personnel to do that, we can deliver on it. So that's the idea of patient navigation in a nutshell. There's also genetic counseling and testing. As you know, a subset of breast cancers that are diagnosed today are based upon, or caused by genetic mutations that lead to either breast cancer or other cancers. So having a mechanism to screen for it, someone with expertise to counsel patients about the results and provide follow-up, that's a service that we'll provide as well. Survivorship. Of course, the story doesn't end once your breast cancer has been diagnosed. There's a life to live thereafter, and sometimes that life involves managing the consequences of the treatment, the side effects of treatment. That's part of survivorship. But also recognizing that you've come to me for a diagnosis of breast cancer, but what about your colon cancer screening? Has that been done? What about your GYN screening? There are other health conditions that are part of the comprehensive cancer survivorship, and we'll have someone in the breast center who will make sure that patients that engage us around their breast health will be managed in a comprehensive way so that we can treat the whole patient, not just the limit problem that they come to see us for. There's more. But you'll hear about it next time.
Doctor, will you also be performing cryoablation?
So there's a question. So cryoablation, tumor freezing, is an alternative to breast cancer surgery. So I gave a talk yesterday, and I started the lecture by saying that my commitment to breast oncology, as is suggested here, is to change the standard of care, and it's driven by the fact that in the context of patients in the care, not everyone wants to do the traditional things. Lumpectomy, mastectomy, it works for most, but it doesn't work for everyone. And so many of the things that I do today have come out of the relationships that I've developed with patients that have said, I want something better. I want to do something non-surgical. I want to have some radiation that's less burdensome than the traditional. So cryoablation is one of those things. And I've been involved in cryoablation during research for the last 10 years, treating breast cancers. And it's come a long way, but it hasn't quite emerged. And the thing that's been necessary is a randomized controlled trial. A trial comparing cryoablation to lumpectomy to the right patients. I'm privileged to have been involved with the effort to develop one. I anticipate within the next year and a half, it'll be launched as a national trial, with the center, the breast center, being a key site for the trial. So I anticipate that we'll be performing this cutting-edge research, as well as other forms of cutting-edge research within the breast center. It is really our responsibility. It's just not enough to do what everyone else is doing because it's working in the past. So we really need to constantly upgrade. Just as we, in other parts of our life, we try to improve wherever we can, we need to improve the service options for women. And cryoablation is a prime example of that, and that's a service that will come forth. And I'll just add that just this past month, we opened a clinical trial for cryoablation. So the trial that I just mentioned, the one that we randomized control trial, is the trial of invasive breast cancer, stage 1 breast cancer. But we opened the trial just last month for stage 0 breast cancer, which is a new treatment option. So spread the word. I have to credit some people in the room who helped to raise the funds for the trial. But it's a game changer. No one dies from stage 0 breast cancer. It might progress to invasive cancer, but we treat it. Even though no one dies from it, we treat it as aggressively or more aggressively than stage 1 breast cancer. It is a disconnect that needs to be solved, and we can solve it by developing less invasive, less burdensome, effective treatments that can be done in a single office visit. That's what that
and
treatment
as
is.
you said, IORT will also be available at the hospital.
So we have one of our early IRT recipients, intraoperative radiotherapy. I credit patients who came to me in the early part of my career, a little earlier, who said, I do not want to have radiotherapy, or I fear radiotherapy. Can we do something different? And so that led to a clinical trial, which I talked about yesterday, that I participated in, which offered a single dose of radiation during surgery as the alternative to the traditional whole breast radiotherapy given over several weeks after surgery. We participated in the trial. The results long-term have been great. You were an early recipient of it, if I may share.
That was 6 years ago, doctor.
Yes.
Essentially with IORT, one surgery, I was out 2 days after. And I was walking, it was really a blessing.
So that should be much more experience that more women should be able to say that. There are a lot of people that still undergoing 4 to 6 weeks of radiotherapy routinely in every hospital in town. We need to make sure that they know that they can have this experience here.
And is it fair to say that your home said no one is offering that expertise around LA?
Right. This particular method that you had is the one is supported and proven by randomized controlled trials, which is gold standard for breast cancer treatments, and for any cancer treatment, in fact. So that is something that is offered uniquely in LA by the Women's Center, by the, what will be, the breast center is currently at the hospital. And, you know, we're now doing it for early stage breast cancer, that's low risk, but we're conducting a trial for high risk breast cancer as well. So it's just a matter of always trying to find a better way, not being settled with what we've already done, because we can always do better if we try. So thank you for bringing that to my attention, and I will stop now.